thank you all for showing up to our next installment of the AJS STARS Roses and Thorns of Academic Surgery virtual seminar series. We've had a couple of these, and I think they've been really good. The purpose behind this is to, provide another platform where trainees across the nation can network with and learn from leaders in the field of academic surgery. And that's who we will be featuring tonight, a very prominent leader in the field of academic surgery, Dr. Benedict Nwomeh. He is a pediatric surgeon, and he's the director of pediatric surgery, of the pediatric surgery residency at Nationwide Children's Hospital. He's a professor of surgery and pediatrics at the Ohio State University, a director of the Wexner Medical Center's Global Surgery Program at Ohio State University. He's originally from Nigeria, earned his medical degree from the University of Lagos College of Medicine, and training stops for him included Ohio State, Lagos University, VCU in Richmond, Virginia, Children's Hospital of Pittsburgh, and several hospitals in the United Kingdom. The focus of his research is on understanding the burden of surgical diseases and building surgical capacity in low and middle income countries, publishing over, from what I could count, over 100 manuscripts. He's a champion of diversity and inclusion, a very skilled surgeon, a productive scientist. I also saw that he's followed by Barack Obama on Twitter. So he's an all-around, really, really cool guy. So we're very excited to be hosting Dr. Nwomeh, and you can take it away.
Thanks, Lamari. Can you guys hear me?
Yes.
Yeah.
Yes.
So is it usual for everybody to turn off their camera? It's kind of boring for everybody to turn off their camera. So it just makes for a different kind of interactivity if I'm just speaking to squares instead of faces. So, not trying to be uncool, not trying to force anybody to do anything differently, but it's, if this is this supposed to be like a lecture or an interactive forum?
Yeah, we like to be interactive. Certainly. Yeah.
Okay. All right. Just trying to encourage anybody who wants to be sort of more interactive, to turn on their camera so that we can actually see and talk to each other. So I just, yeah, go ahead.
And if folks are in a place where they can't unmute or show their camera, if you want to still participate, feel free to post questions in the chat as we go, and I can kind of help monitor that to make sure we're not missing anyone. So.
Okay. So I just want to start by telling you a bit about my journey. So as Lamaria said earlier on, I was born and raised in Nigeria. I think the earliest that I can remember telling anybody, articulating my desire or my ambition to be a physician was perhaps when I was about 8 years old. My mother was a healthcare worker. She was, she was a nurse midwife and worked in the community where I was born. So from my early childhood, I saw her taking care of patients. But right in the village where I was born, it was a village, a real African village of, maybe about 5,000 people. She took care of, everybody's malaria and cough and dysentery and all those common conditions that people had. She was also a midwife. So almost everybody my age in that community was delivered by her. And the one thing that happened was that we did not have a doctor in the health center where she worked, but there was a doctor that came from the nearest big city. The doctor visited to do consultations maybe about once a month. But guess what? When the doctor came to that health center, my mother was the person that worked with the doctor. So every time the doctor came, of course, I would always kind of go into the, I was always running around my mother. And the doctor would always say, who is that? Who is that boy? Who is that boy that is always around you? And I always remember my mother saying to the doctor, this is my son. This is my son. And the other thing that I always remembered was that this doctor, he always wore a big white coat. And he was so well respected. Everybody respected him. It was like the big doctor came to the village. And I was only 8 years old, 7, 8 years old. And all I ever wanted to be was like that doctor. And it wasn't because I wanted to save the world, to be frank with you. I mean, because I've heard so many, young medical students talk about why they wanted to be doctors. They want to be surgeons. They want to be, they want to save the world, right? The reason I wanted to be a doctor wasn't because I wanted to save the world. I just wanted to be respected like that guy that came to the village, because everybody respected this guy, and I just wanted to be like him. So, so he would call me and he say, I mean, we didn't really have a conversation, but I just knew that he would treat me so nicely because I was my mother's son. So for me, that was how it started for me. It was just my North Star. So I became a doctor because I wanted to be as respected as that doctor that came to the village. So I knew I had to work hard. I was always the best in my class, through elementary school, through high school, and through medical school. I went to medical school in Nigeria. There was political turmoil in Nigeria at the time that I went to medical school. So I knew that if I really wanted to achieve what I wanted to be in my career, that I had to leave the country. So I left. At the time I left the country, I really didn't know what specialty that I wanted. I mean, maybe I thought about surgery, but to be frank, I really did not know what I wanted to do. I just knew I wanted to leave the country. So I went to the United Kingdom, and I settled on a surgical career when I got there. I spent 4 years in the United Kingdom. And I had a chance encounter with a surgeon in Manchester in the United Kingdom. His name is Adrian Bianchi. Now, if any of you is into pediatric surgery, you may have heard of the Bianchi procedure. It's a type of surgery that you do to lengthen the intestine, for kids with short bowel. It's called it's an intestinal lengthening procedure called the Bianchi procedure. So I had read about this procedure in preparing for some of the surgical tests that I did while I was in the United Kingdom. So I was working for a surgical team in the University of Manchester area, and I was actually doing a posting in orthopedics at the time. But I happened to be working at a Pendlebury Children's Hospital in Manchester, and I learned while I was covering pediatric orthopedics at the hospital that there was something going on in the OR for pediatric surgery. And that Mr. Bianchi, surgeons in the UK are called Mr. So I heard that Mr. Bianchi was doing an operation. So I was like, is that the Bianchi? And they said, yes, it was the Bianchi, literally the god of pediatric surgery. So, I was not busy at the time. So I said, I'm just going to go see what he was doing. So I went in to see Mr. Bianchi operate. And I was just so wowed by this guy. The thing that amazed me about him was that he had such big hands, such big hands. And yet he was so gentle. I just could not imagine how a man with such big hands could be so gentle. He was operating on a baby that maybe was about 4 pounds. And I can't remember what operation that he was doing because I was so distracted by his big hands and this tiny baby that he was operating on. And I was just there, I watched him do the entire operation, and I didn't say a word to him. I mean, I was so afraid to talk to him because he was the god of pediatric surgery. So I left, and I was just thinking about the encounter. Then several months later, I was now in another hospital. You know, in the United Kingdom, you move from one hospital to the other when you are a trainee. So I was now working in another hospital, a different post, as we called it in the United Kingdom. And this was now a cardiothoracic rotation. And my consultants, attendants in the United Kingdom are called consultants. My consultant, consultant thoracic surgeon, we had a child, a teenage child with a thoracic mass that we needed to operate on, me and my cardiothoracic consultant. So he said to me, you know, this is a child, so we probably should invite a pediatric surgeon to help us. And guess who he invited to help us? The god of pediatric surgery, Mr. Bianchi. So I had this incredible experience of actually standing on the other side of the table to operate with Mr. Bianchi, the god of pediatric surgery, the man with the very big hands. I can tell you, like, you know, I did assist Mr. Bianchi in doing this operation, but I have no memory of the operation because I was just so distracted with his big hands and just this incredible experience of just being in his presence and operating with him. And I still did not summon up the courage to even talk to him because I still could not process the experience of having to tell my friends right after the case. I called all my friends and said, guess what? I did an operation with Mr. Bianchi, you know. So that was kind of how I got enthralled by the idea of pediatric surgery. The fact that I had a chance encounter with the man that described this big operation, the man that wrote all the chapters in shotgut, you know, intestinal failure, you know, the operation and all the textbooks that I read. So when I applied for surgical residency and eventually matched at the Virginia Commonwealth University, I you know, indicated in my application that, you know, I want to be a pediatric surgeon. But I wasn't completely sold on the idea of pediatric surgery because I was also kind of interested in surgical oncology. So when I started my internship, I was really confused. I wasn't sure, you know, was it this pediatric surgery thing that was not really rooted out of any real idea about I love children or anything. It was just because of my infatuation with one man's big hand, right? But I had another experience with cancers, and I thought, you know, maybe I wanted to do surgical oncology. So the reason I related this story is that sometimes young people say they want to do a specialty, and it's not out of any genuine experience, and that was the case for me. And I think you have to search yourself whether you are attracted to a specialty out of something really genuine. And I think in my case, when I started internship, if you look at my original application to residency, it said interest, pediatric surgery, or surgical oncology. The best thing that my program director did for me was that he put me in surgical oncology as my first rotation as an intern. Because at the end of my first rotation as an intern, I promptly hated surgical oncology. Now, I mean, I apologize to any of you that is interested in cancer because it's a very worthy specialty. I mean, I think cancer surgery is great. And the reason I dislike surgical oncology, I probably shouldn't have disliked it so much, but there were just some peculiar circumstances surrounding that specific rotation at that point in time in my career that made me dislike surgical oncology. But you know, that's what it was. At the end of my first month as an intern, I realized that, you know, maybe that was not the thing for me. So that left me open to really explore the idea of pediatric surgery. But I still was not sold on pediatric surgery because, in my residency in Virginia, we did not have pediatric surgery as a rotation during my internship. And actually, because I had been burned by my very quick dislike for surgical oncology, I did question myself whether, this my interest in pediatric surgery was actually real or not. I was like, okay, if I'm going to dislike surgical oncology so quickly, I got to check myself about this my interest in pediatric surgery. So I actually said to myself, maybe I should explore everything else. Maybe I should explore everything else. So for the rest of my PGY1 and most of my PGY2, I actually decided to explore every other specialty. And for a while, I was actually on the path of cardiothoracic surgery. So I was a free agent for a while. I really, it was kind of an amazing thing. I came in for pediatric surgery and surgical oncology. And I actually, by the time I started my PGY2, I bought this big fat textbook on electrophysiology because I thought I was going to be a cardiac surgeon. In my program, everybody had to do 2 years in research. So I was signed on to go to a cardiothoracic lab, and I was going to go to an electrophysiology lab because I really thought I was going to go into cardiac surgery. So, I was studying up cardiac physiology. I was so ready. I had written a grant for my cardiac lab and I almost forgot everything about pediatric surgery. But in my program, we did our first pediatric surgery rotation as PGY2s, and I did it late in my second year. So when I got into pediatric surgery, oh my God, I just, I realized why I had fallen in love with kids in the first place. I was just in my element. I loved the kids. I loved the parents. All my co-residents hated the rotation. But I was in love with everything in pediatric surgery. And, I couldn't quite explain what was going on, right? I was like, is this for real? I knew that it was for real when two things happened at the end of my rotation. The nurse practitioner on pediatric surgery called me at the end of the rotation and said, what are you going to do with your life when you are done? I was like, I don't know. She said, I think you're going to be wasting your life if you don't do pediatric surgery. So that was the first thing that happened. The second thing that happened was that the medical students on the service, went to the chief of pediatric surgery and said that nobody had ever taught them more than I did on the service. And based on the account of the medical students, the chief of pediatric surgery, Dr. Charles Bagwell, who, by the way, is still in practice today. He's still, I think he's just retired as the chief of pediatric surgery, but he's still in practice. He was my first mentor in pediatric surgery. He called me to his office and told me that he recommended that I did pediatric surgery. So if it was not for those two medical students and the nurse practitioner who validated what I was beginning to feel about pediatric surgery, I probably would never have had the courage to go back to my original love, which was pediatric surgery. So even then, I still did not have, I still was not sold on the idea of pediatric surgery because pediatric surgery was very tough to get into at that time. At that time, there were only about 18 Black people in this country that had ever been trained in pediatric surgery. Only 1/8. By my calculation, if I had actually gone through with going into the match in pediatric surgery and I would be successful, which would have occurred like 3 years later, I would be number 20. At that time, if you're a Black person and you matched in pediatric surgery, you actually got a secret number. So I would be number 20 if I became a pediatric surgeon. So I was doing the math and I was like, the odds are really not in my favor, right? And then somebody called me and said, you know what? Your chances, there's no way in hell you're going to match, right? You're a foreign medical graduate, you have an accent, and then you're Black. That's like 3 strikes against you. And there's just no way you're going to match. Somebody actually run like a fake statistics and told him that my chances were like 0.01% or something like that. Okay, so the reason I told you all this story, there are just 3 lessons I want you to get from this story, and then I'm going to quit talking and then allow you to ask questions. Number one is some of the people around you that you might think are not important might end up being the most determinative of your career if you paid attention. If you paid attention, the nurses, the nurse practitioners, the medical students, some of, if you will, the lowly people around you, first of all, treat them nice, but pay attention to them. Because I think in my case, they really meant a lot in helping me to kind of decipher which track my career was going to go. Number two is, I think a lot of medical students, even residents, tend to dive too early into making a career choice, and sometimes for the wrong reasons. Sometimes because they're trying to impress an attending, or a senior resident. I think you should only choose your specialty because that's something that you really love to do. It's like you want to go to work every day enjoying what you do. So be careful. I don't think there's any shame in trying out something and realizing, that's not really what you want to do, retracing your step. So I think there should be no rush, in my view, on choosing your specialty. Wendy, I'm not sure what I said this to you when you were a medical student of my service, but I often say to medical students, even if you come on the surgical rotation and you tell me that you want to go into surgery, I may say a variation of this, even if that's what you want to do, even if that's ends up being not what you want to do, that's still okay. And that is not necessarily discouraging you from pursuing surgery. But I don't think that you're coming on my service. I'm not going to treat any medical students differently whether they want to do surgery or not. And I'm still going to write you the best letter of recommendation, whether you go into pediatrics or family medicine or surgery or whatever you want to do. Because it's okay to change your mind, even if you say you want to do surgery and then later change your mind. The third thing, of course, that I want to say is, if you have the guts to know what you want to do and you feel competent to do it, don't let anybody discourage you. Whether you are a woman, whether you are a minority, whether you are Latino, African American, Native American, whatever hyphenated American that you are, or whether you're a white male, because sometimes, white males feel like, they're being left out of this discussion. Whatever you are, don't take no for an answer if you feel that you have the competence to be able to do it and you are ready to work hard to do it. Because the statistics don't often tell the power that you have in yourself. Okay, I'm going to stop.
That's awesome, Dr. Nwomeh. I love hearing you talk. And so, yeah, we definitely want to open up and let anyone ask any questions that they'd like to ask. You can definitely unmute yourself, or let me make sure that I can see everyone. You can raise your hand. You can ask questions in the chat. No one's jumping to asking any questions. I'll start with one question. Or actually, I'll let Aaron go ahead.
Thanks so much for doing this for us. Really appreciate it. So you mentioned that you did a lot of your training in UK first, and then you switched over to the United States. I was just wondering, like, I feel like as medical students of our URM, underrepresented minorities in the U.S., it's kind of challenging to kind of figure out mentorship or just seeing like a path to follow. Is it similar when you were in the UK that you found it difficult to kind of find that mentorship, or did you feel like it's a little different when you like compared to what you see here in the States?
Well, mentorship is a two-edged sword. There's a role for the mentor and there's a role for the mentee. So I think each system, is peculiar to itself. I think at the time that I was in the UK, it's probably much different than it is right now. I think that the training system has changed. The training system has, from what I have learned, become a little bit more American, since my time. The mentorship structure has probably become a little bit more American. I think when I came over to the United States, I found that we had a better mentorship model here than we had in the UK at the time that I left. But I think that since then, it probably has changed more towards what we have here.
Thank you.
Dr. Nwomeh, I would love to hear more about your global surgery efforts, your leadership role with Ohio State, and just the things you've done. One question in particular is, I guess, how does your leadership role for the global surgery program work at Ohio State? And is that something that you had to create, or was that something the institution was already pushing for global surgery?
Well, I was already involved in global surgery efforts at a national level for probably a decade or so before we created our global rotations program here at Ohio State. At the time that we developed our ACGME and ABS approved rotations here at Ohio State, I would say that many institutions in the United States had come to a point where this became a highly desired aspect of training by many applicants for residencies across the United States and many residents across the country. The opportunity to, as I put it, to become global citizens, which is really the linchpin of our program at the Ohio State University. I think that there may be programs that want to strengthen the surgical skill set of their residents by sending their residents overseas to go do cases overseas. That is not what we try to do at Ohio State. Although, of course, we want our residents, when they go overseas, to participate in clinical care, take care of patients and operate as much as they could. But that is not the primary thrust of our program. The primary thrust of our program is for our residents to inculturate in the global sites where they are, to learn, clinical care and the case mix that are not available at home, to become global citizens in the true sense, to learn new cultures, to learn clinical care that will make them able to take care of patients from around the world, because we have a global population here in Columbus. We have an immigrant population here in Columbus. So we want them to be competent in being able to, take care of those patients that they will encounter both here in Columbus and throughout their career, so that they would just have that global and cultural competence that we feel that every surgeon living in the modern world should acquire. So it is really more about, that broad set of skills and also leadership experience that we feel that is most important in developing, this global rotation, rather than just going to count cases.
Wendy has a question in the chat, and I can read it. She expresses her gratitude for the wonderful discussion. She says, I'm curious about the transformations you've made in both your personal and professional life that contribute to your excellence in your field and uphold your legacy. Could you also share the challenges you faced and how you managed to overcome them?
Clearly, the most important challenge that I have faced, like every first generation immigrant and foreign medical graduate, is that of having two families, separated by hundreds of miles and at least one ocean away. In my case, my family is in Nigeria, and you can't travel transcontinentally often enough to go see those families. So I think that separation, having two homes, being citizens of two different countries, I always say it's much easier for my children here because they're Americans and they've only known one country, and it's so much easier. They don't feel what I feel. I'm always a Nigerian at heart because that's where I was born, that's where I was raised, and in many ways, that's where I still call home. So that's I think that's a lot of the challenges I have has to do with just living that divided life. I will stop there. But I think that every immigrant on this panel understands that.
Isaiah, go ahead.
Thank you for being with us today, giving your time. I had a question as far as, well, one thing I noticed from this conversation was that you really want to be open-minded. For somebody that is really interested in academic surgery, even though I'm trying to still be open-minded to other things, how should I go about finding my research, I guess?
Yes, that's a very good question. What level are you right now?
I'm a upcoming third-year medical student, but I'm still just trying to explore what type of research would be can I get involved with.
Good. So I assume that you are talking about research during residency, because a lot of research when you are a medical student, will be, I would say, just to be practical, would be research that is available in your institution, and will be research, as I often say, it's a research of opportunity, right? So you're going to find whichever faculty member that offers you the best opportunity to do research, just to be practical about it, because you don't want to waste too much you don't have too much time. So it's going to be whatever is, like if I were a medical student, I'm just going to find which faculty member has the best project that is going to offer me that is going to fit in with the little time that I have, that is going to allow me to be the most productive, right? So that's the way that I'm going to think about it. Now, residency is a different ballgame. And I would say if you're a medical student applying for residency, if you have an idea of what specialty, that you're going to be applying to, and you think you're going to be doing research during your residency, then that should definitely play a factor in which residencies that you apply to. If we're thinking about surgery, for example, you should be asking yourself, okay, does this surgical residency even offer the opportunity for research? who's going to fund the research? There are many residencies that require you to do research. So if you want to do research, I'll be going for those, because if they require you to do research, then they probably already have figured out how to fund your research during those 2 required years of research. So that's the way that I applied to my residency. I went to VCU because at the time they required 2 years of research. It was compulsory to do research. So they paid for the research. And they had lots of faculty with R01 funding. So everybody, all of us, the 5 of us that were categorical residents, we didn't have to go elsewhere to do research, because there were so many faculty members there with funding, with labs. So that's the way that I will be looking for residency. Will be, am I going to be applying to a place where there are faculty members with lab, with funding, and how is the research paid for? Because if you want to do research and you end in a place where it is only 5 years straight, right? And now you're in PGY2 and you're going to say, okay, I want to do research, and they say, well, we can't afford to pay for it, then that's kind of a problem. I mean, you may be able to find it, but it's kind of harder. So I think early planning and knowing what you want to do and then discussing your intention ahead of time will save you a lot of trouble down the line. And obviously, if you already kind of know what subspecialty that you intend to go into, I mean, Wendy know that we had this discussion before she applied to her residency. I mean, if you're thinking, for example, about pediatric surgery, we pediatric surgeons, we often require our applicants to have done 2 years of research. So if I was advising my medical students who tells me that she wants to do pediatric surgery, she knows that I would have told her, that I want to see your list before you put in that match, because if there is a top 10 on that list that does not offer research, I'm going to say, no, right? Because that's not going to lead you to where you want to be.
Shay or Sean?
Hi, Shay. Thank you so much, Dr. Nwomeh. My name is Shay Stewart. I'm a 3rd-year resident at Howard University Hospital, hopefully applying to pediatric surgery in the upcoming cycle. Thank you so much for your time. I had a couple of questions. One is, what would you say would be the perfect recipe for someone aiming to match into pediatric surgery? And 2, once you've matched, how do you truly maximize your experience during fellowship? And how do you become the best fellow that you possibly could be? What do you think are the top 3 tips you would give someone as an applicant, and if they're successful as a fellow?
Okay, there's a lot to unpack there. So remind me, what level are you again now? I'm
a 3rd-year resident at Howard University Hospital, okay. So I'm rising PGY4.
Okay, so if you are a 3rd-year resident, rising to a PGY4, first of all, you and I need to connect at some point, okay? So if you're a 3rd-year resident, I assume that you would have done or planning to do 2 years in the lab or some professional development experience, because as you know, that's important. So if let me just back out. So if I had an intern coming in as PGY1 or even applying for residency, saying I think I want to do pediatric surgery, although I don't think it's essential to, as I said earlier on, I don't think it's essential to have identified that interest in pediatric surgery even that early. But let's say that you come in as PGY1, and say that you want to do pediatric surgery. Like in my institution, I meet with every PGY1 right as they show up on July 1. If they say they think they want to do pediatric surgery, I would have met with them in their first week of residency, and then we go through this discussion, right? Because I want to have a discussion with them about the fact that you need to be the best resident in the program. I mean, no question. I mean, if you say you want to be a pediatric surgeon, you need to be the best resident in the program. You need to be the best intern. I want to see you win the best intern of the year award, right? You need to be the best during your rotation on trauma, on surgery, on breast, on vascular, and everything, right? Because as a program director in pediatric surgery, I want the best resident in everything. So it begins from there. I want you getting the best in your app site. You need to be hitting the best scores in everything. So that's how it starts, okay? I mean, it doesn't do me any good for you to say, oh, I love kids, but then you're failing your ABSITE. Or, you know, I'm getting like bad evaluations on vascular, or bad evaluation on surgeon, or bad evaluations on, you know, trauma or anything else. So you need to like be absolute best. No complaints about your behavior. You know, you're not talking down on nurses, or you are not dictating your up notes, or, you know, you are not doing, you know, you need to like, you know, be like the best in everything. So it begins from there. So I can't emphasize enough how, you know, this aspect that I talked about, because I think that there are lots of people that say, I want to do this specialty, and they think that all it requires is to just hang around with the doctors in that specialty or go to their meetings, and they think they can just slack off in everything else, right? You got to be the best in everything else. No, haven't been the best in everything else, then you need to do the professional development that your specialty requires. In this case, pediatric surgery, we do like people to have spent at least 2 years doing something. It doesn't have to be basic science research. It could be, you know, outcomes research. It could be research in education, ethics. It could be research in, you know, global surgery, or, you know, something, just something to say, I've taken some time off to develop myself in some area. Some people do like a fellowship in critical care, for example, or something else. And then the evidence for your work in that professional development is the publications and presentations. You know, if you garner some prizes during that period, all the better. So at the end of those 2 years, you go back. Some people do that between their PGY 2 and 3. I think that's the best time to do it, because it does give you time to come back as a PGY 3 and then 4 to solidify your clinical skills. And then you apply to the match usually during your PGY 4. And during that PGY 4, when you apply, you need letters of recommendation that testify to all those things that I talked about. Like those letters of recommendation, they need to be hidden the notes on saying, you know, he was the best resident on vascular. He was the best. Everybody says he's the best thing since sliced bread. You know, his operative skills are top notch. If you don't have letters of recommendation that attest to all those things, you might have a tough time matching, because, you know, we pediatric surgeons, we like people that are very, very competent, because you're going to be taking care of those little precious kids, and we want the best. You know, we want people that are good surgeons, that have good clinical acumen. I mean, everybody loves kids, but we want the best to take care of them. So I think it's just as simple as that. You know, there's really no mystery about how you match in pediatric surgery. It is, you know, get good ABSITE, be a good doctor, don't cause anybody any problems, so that they don't say bad things about you, and then come for the match. And then, you know, it's, you know, and, you know, and it's, I think that is the same thing that other specialties want too, by the way, you know, because other like colorectal is really very competitive, so junk is very competitive, and I think it's the same attributes that they want.
Thank you so much. Appreciate that. And I'd love to connect with you.
Yeah, I would love that.
I have a question.
Yeah.
I'm curious if you feel like there's any particular effort towards, you know, improving justice or equity in academic surgery, or even in just taking care of patients, that you've had the most impact. I'm sure you've tried it all, but what has been the most effective, do you think, and most rewarding in those efforts?
Yeah, thanks for that. Yeah, you know, I think, as you know, as some of you know, my domain has been in training and education. You know, by the way, I think that justice and equity, and you know, whatever acronym that you use, is, you know, it's a task for everybody, right? You know, it's not a task for Latinos or for Native Americans, or, you know, Black people, or for anybody, right? You know, this is an American problem, you know, and I think we're all going to win together, or we're going to lose together, right? You know, so I don't consider this a unique, you know, problem for me because I'm a Black person, or for, you know, Wendy because she's a woman, or for, you know, this is you know, so I personally don't want to be pigeonholed, you know. So, you know, this is something that I need to do. In my institution, for example, I work at Nationwide Children's Hospital. In our surgical department at Nationwide Children's Hospital, I belong to the, we have a DEI leadership team, which I'm very happy to serve on. But the leader, our director, is a white woman who I actually think is much more qualified than any of us to be the leader of that team. She's an orthopedic surgeon. She has very demonstrated competence in that area. She actually has made more publications in that area, promoting diversity in her orthopedic field than any of us has done in our respective fields. And I think that is the way that it should be. I think the way that I look at it is that if you look at our patient population, for example, in Columbus, in our children's hospital, somewhere between 15 to 20% of our patients are African Americans. When those patients come to my clinic, right, if they don't see a Black face, they don't trust you, right? If they don't see Black people among their providers, among the cleaners, among the nurses, among the drug doctors, among the leadership, they're not going to trust you. They just think you're playing them. So no matter what you are doing, you are not going to meet your goals for taking care of them. So if we want to provide good health care for our patient population, we have to have a mix of healthcare workers that look like our patient population. So I think to me, it is just doing right by our patients. If taking good care of our patients is the North Star, we have to have a healthcare workforce that looks like our patient population. So to me, it is about achieving good outcomes for our patients. It's just as simple as that. So I think that those of us who are in the sphere of training, we owe it to our patients to train a healthcare workforce that looks like our patient population. So, when I became the president of the training directors in pediatric surgery, I just looked at the data that, children across the United States, constitute, again, that data, 12 to, 20% of our children across this country are minorities. But, only about 4% of pediatric surgeons in the United States were African American, and maybe about 3% were Latino. So we were failing our patients by not providing them pediatric surgeons that mirrored the population that we were seeing, and clearly we were not going to be achieving equitable outcomes for those patients. So the little that I could do from my perch as the leader of the Program Directors Association was to provide this fact to my colleagues. And there was a unanimity among my training director colleagues, without exception, that it was something that we needed to remedy. So there were a few things that we did, during my term as a Program Director, President, to try to increase the diversity of the workforce in pediatric surgery. There were several initiatives that we started during my term as a president that I believe has improved the way that program directors in pediatric surgery, and I think several others, especially, for example, we started holistic review in my program, and I think in many programs in pediatric surgery. We started holistic review, which is, I think, what a lot of general surgery residencies now do, and a lot of medical schools now do. So we do holistic review. We're still committed to excellence, right? Everything that I told Chai about what it takes so much in pediatric surgery is still what it takes so much in pediatric surgery. You still gotta get good grades, you still gotta be a good doctor and all that stuff. But we don't just look at, like in my institution, we still have like a matrix, holistic review metric, scoring sheet that will assign the same points to every university program, for example. And our definition of a university program will assign the same points to Harvard as to Hopkins, as to Howard, for example, right? So, you get the same points if you're a university, because we want to recruit. In my institution, for example, we would definitely say we're an academic program. So we want to recruit fellows from academic general surgery program. But our definition of an academic general surgery program is a university program. And University of New Mexico is a university program. Harvard University is a university program. Howard University is a university program. The Ohio State University is a university program. There was a time in the past where there were some of these institutions that I mentioned that would not even be looked at. But what we say is that every university program should be given the same score. So that's kind of, some of the changes that we made. And I don't want to bore you, but there were a host of other changes that we made that basically gives a lot more, candidates, at least a foot at the door to be looked at, that would never have been looked at in the past. But again, you still have to, meet, the bar to be selected.
Dr. Nwomeh, I can come up with another question. Going back to global surgery a little bit. We just want to know if you could talk about maybe the parallels that you see between marginalized populations in America and the healthcare limitations that exist in low income and middle income countries. Have you seen any parallels there? Do you think there's any kind of like exchange that can go there, like ideas to inspire, like how can we tackle those problems that exist in a high income country like America that also exists in other countries?
Yes, thanks for asking that question. So, earlier you had asked me about, some of the lessons that we learned from our global surgery program. There was an interesting study that was done, maybe about 10 years ago at Michigan State University. And, essentially what they found was that when they sent residents to on global rotations, when those residents came back to the United States, those residents became a lot more frugal in their utilization of resources in taking care of their American patients. And they actually measured their utilization of resources and found that there was a statistically significant cost savings to their healthcare system among those residents that had taken rotations overseas. And they published this. So you can translate this to say that if we have many more residents doing rotations overseas, there could actually be benefit to us here in America, right? Because the one thing that we all know that we do very well here in the United States is that we waste a lot of resources. Residents who operate with me will know that one of my pet peeves is that when I get handed over a suture by a nurse in the operating room, I make that suture last. Like, I don't take a suture, tie one knot, and throw it away. It's probably a habit that persisted from my training in medical school in Nigeria, because, when I was trained as a medical school in Nigeria, we didn't throw away sutures, right? I mean, I know that sutures, they tell me here that sutures, oh, don't worry about it. It's, we throw away everything because it's not that expensive. But, when I was in Nigeria, we didn't have sutures. I mean, we just couldn't afford to throw away things. So I'm very used to getting, 6-7 knots out of one suture strand, and I still continue to do that up till today. So when residents go overseas, they make do with nothing, and then they come back here and they learn that, you don't have to order H&H 10 times a day, and they actually check the results of the labs that they order. There have been studies that show that a lot of people order labs here and they never check it. They just order it because it's something that they do. They don't actually check the results, right? People just order morning chest X-ray, every day, but they don't actually look at the chest X-ray. So when you go overseas and you know that you get one shot at ordering a chest X-ray once a week, you will never commit the error of actually ordering a chest X-ray and then not checking it. So I think that there are definitely lessons that one can learn from taking care of global population and marginalized or immigrant population here in the United States. We have very similar populations. Not to disrespect anybody from, say, Appalachia here, or people in native communities here, or people in inner city America here, and in many other poor communities. So if you want to help poor people, you don't have to travel halfway around the world to do that. In fact, I wrote an editorial with one of my residents, arguing that many of us, as we kind of ascend in the medical ladder, sometimes we become jaded. Sometimes we become jaded with sometimes some of us lose our way. Sometimes we forget why we came into medicine in the first place. And I argued that everybody should, at some point, experience either doing a global or rural rotation. Have some experience in one or the other. As a panacea for this sense of experiencing some distance from medicine that some people maybe burnout is what happens to many of us along the way. That one way of rejuvenating, that sense of mission that brought all of us, I hope, that brought all of us into medicine, is to actually go to places where people have need and where people can still say thank you for what you do for them, is to go to rural America or go overseas to take care of people. And that's really something that I recommend for everybody to do.
Awesome. And there was one question in the chat, I think, that got missed earlier, Lamario. I was just going to bump up. Is that okay?
Sure. Yeah. Go ahead.
I know we're getting close to time, but Dr. Nwomeh, you talked a little bit about your journey to surgery. Wasn't even your necessarily initial plan when you went to the UK. And one of the students was wondering, they really like their surgical rotations, but obviously in med school, there's still limited exposure to what residency and attending life is really going to be like. And so what tips would you give for folks who have an interest in surgery or in medical school to really kind of confirm that decision before applying to residency?
Yes, clearly the experience that I described, in Nigeria is different here, because I think that here you're kind of forced to make a choice earlier on, right? In that other system, you are not, even at the time of internship, you are still kind of doing a rotating internship among multiple specialties, so your choice can be a little bit delayed. But here, you have to apply to a residency in some specialty. So, you have to make your decision, sometime before your fourth year. But you don't have to make your decision during your first third year rotation. I think a lot of people feel like they have to make that decision in kindergarten. You don't have to. You can delay that decision a little bit, into your third year, to at least do a few third year rotations before you make your decision. So that's all I'm saying is that you could wait until the last possible minute that is practically possible, just to confirm for yourself whether you like one thing or the other. So again, it doesn't have to be the first week of your third year, or clearly it shouldn't be the last week, but there is probably a sweet spot to allow yourself to experience other things before, as many things as possible before you decide what it needs to be.
Would you be able to ask your question really quickly?
Thank you, Dr. Nwomeh. I just wanted to quickly ask from your experience coming from Nigeria to the UK and then to the US as an IMG, what were some of the things that you think are the most important in succeeding as an IMG during residency training and moving forward? Because I have exact same trajectory from Nigeria to UK and now moving to the US.
Yes, yes, depending on, for me, I think that the most difficult transition, I moved from Nigeria to the UK, so that was a big transition, and then moved from the UK to the US. That was an even bigger transition. They moved from, you might think that moving from a very, low income country like Nigeria to the UK would be a bigger transition than moving from a first world country, the UK, to the US. But that was not the case. Moving from Nigeria to the UK was fairly easy for me. Part of it was because of the sort of colonial similarity between Nigeria and the United Kingdom. Nigeria and UK were similar in many ways. The English language was sort of similar. We kind of used the same lingo. We read the same medical textbooks. The system was, similar in many ways. So the transition was fairly, was not that hard. But moving from the US, from the UK to the US, was very, very different. Things that you would not imagine were a barrier to me when I started as an intern. And I'll just give you an example. Doing an HMP is not called an HMP in the United Kingdom. It's called clerking a patient as a clerk. I would say to my chief residents, I have clerked the patients, and they wouldn't know what I was talking about, right? I would have seen the patient done everything the night before, and my chief residents would say, Dr. Nwomeh has not done a thing on the patients, and only because I had not used the correct lingo. And I would get all these bad evaluations, right? I would literally get like the worst evaluations of everybody in my year. And it was because we were not communicating, because I was using the wrong terms. I would say I would just say things, and I was speaking British English, and I would have saved myself a lot of trouble if I had spent a little bit of time to learn some American English before I started residency. But I came to the United States on a Sunday and started residency on a Monday. So there was sort of a lot of cultural unawareness, when I started, and that caused me a lot of trouble. So I think that it is certainly one thing that I would recommend, for anybody coming from overseas, is to allow yourself some time to inculturate. It can save you a lot of angst. I think your knowledge of English is usually pretty good, just not American, English, right? Okay. And your knowledge of medicine is usually super good. And there are also some behavioral, things with the medical community. For example, in the Americans, I kind of learned this the hard way. In the British system, it was quite normal for an intern during a ward round to spend time teaching medical students on ward rounds. So it was very normal. I got into a lot of trouble for doing that, when I was an intern. The chief residents didn't like that. It was like, you have a bloody intern, just do what you're asked to do, So, I like to teach a lot, and of course I had a lot of training before I came to the United States. My chief residents did not, appreciate, me as an intern. I was just supposed to just do the intern work. And so I would probably have saved myself a lot of trouble if I just kept shut, and never talked to any medical student as an intern, and then just did my work. But in the British system, the interns were expected to teach the medical students a lot. That was considered part of your responsibility, and you would never have gotten into trouble for doing that. But when I was an intern, I got into trouble a lot for doing that. So many of it were just kind of cultural adaptation things that I did not, I was not aware of.
So in the chat, it's been asked if you could share your email with participants.
Sure, happy to do that.
Okay, yeah. I was gonna say I could email it to everyone as well, but awesome. So it's been a pleasure to listen to you and learn from you. I really appreciate you taking the time to talk with us and share your wisdom. Thank you everyone else for joining. Definitely want to try to respect everyone's time this evening. We will be having our next virtual seminar series in early August. Happy that we've been able to have these, and Dr. Nwomeh, we will be in touch soon about writing things up for this one. So everyone, thank you for being here. Dr. Nwomeh, thank you for sharing a little bit of yourself with us. Everyone have a good evening.
Okay, bye.
Thank you.